Live, live. Live. Good evening, everyone. Uh, so, once again, good evening, esteemed doctors. My name is Vivek Pandey. I am the lead marketing for EISAI India in the field of insomnia and multiple sclerosis. It's a great pleasure on behalf of EISAI India that I welcome you in today's highly anticipated international speaker program in the field and management of insomnia that is going to shape the overall management of insomnia in India in some time. So I'll first of all, I think it's a great pleasure to have Dr. Filizi, our special guest, flying all over from US in India to share his expertise of decades in insomnia management and the emerging therapies in management of insomnia across the globe. So with this, I'll just take another 2 to 3 minutes of yours time to introduce on why we are here, why is EISAI in India, and what is the future that we hold in doing this kind of program for further. So with this, EISAI is a Japanese origin company with a very long heritage. We have a presence of around 85 years in the research field, delivering best of cutting edge scientific products in management of therapies where there is a lot of unmet need for patients. And with this, we have close to 40 subsidiaries and 11,000 employees globally working in the area of research, quality development, API, and marketing across the globe. And we have a very strong expertise in specifically two areas, that is neuropsychiatry and oncology, where we have cutting edge products and pipelines for futures to meet the unmet need of both neurology and as well as oncology and immunology patient. As I said, we have close to being a Japanese company and origin, we have 40 subsidiaries that is spread all across the globe. Starting from Japan, in Asia Pacific country, we are present across in all the other countries, in European region, as well as in North American and South American regions with 40 subsidiaries. And not only that, we have a very strong presence with 14 drug discovery centers, R&D, clinical research sites, and 9 production sites. And as you can see in Vizag, we have our own one of the biggest manufacturing plant globally for EISAI, which houses close to 400 plus researchers, scientists, API developer, and that is one of the global hub for delivering quality medication for not only Indian market but also European and American market. But it all boils down to our philosophy of HCC, that is spending that 1% of EISAI employees' time with the patient, talking to them, finding their unmet need, and coming up with cutting edge innovation, solutions, patient access program, and future pipelines, as you'll see in some slides. And I think this slide summarizes our philosophy. That starts with Aricept, the global leader in management of Alzheimer. We are the original originator of donepezil, as many of you know. Aricept now globally dominating as one of the lead solution for Alzheimer's. Starting in 1996, later on we came up with in the management of epilepsy with zonisamide under the global brand name Zonegran. That is one of the pivotal and level A evidence drug by ILA. And then very recently in epilepsy only, we have launched Ficompa, the latest third generation anti-epileptic drug, which is doing a lot of effort in shaping how epilepsy is managed. And why we are here today is because 3 years back, EISAI in India and globally came up with Devigo, India's first DORA and globally one of the fastest growing DORA, and that is shaping how insomnia is managed and setting up a new standard of care in management of insomnia. And I'm very happy to share today that in India, very recently, as last week, we have got an SEC approval to bring Leqembi in India. So that is one major breakthrough of what we do and how we do, and we continue to bring those cutting edge solutions to India. Not only that, we have a very strong presence in primary care physician. But when you talk about rabiprazole, one of the highest PPI is an originator of EISAI Pharma under the brand name Parrot. And in oncology, also have a very strong presence with Heleven and Lenvima that shapes and supports the need of patient care, cancer patient care. But what we do is not only from our therapy, but we also expand into therapy where which we are not there with a very strong patient support program. Like as you can see, we are very strongly supporting children with special need, with autism, cerebral palsy. At the same time, women with a mental disorder in areas where the access of medicine is not there. We continue to support those NGOs and the societies that can bring some difference in the life of both this challenge children and mental women with mental health issues. And this all comes with a very strong patient support program across all the therapies that were present in, be it in dementia, as you know, memory clinic, one of the flagship program globally and in India, in setting up the care for close to millions of dementia patient. Even in epilepsy, one of the strongest patient care program that has been running from now close to 8 years as in leave free, both for our profiles of Zonegran as well as Fycompa. And then we continue to innovate further with our patient access program to make it those innovation, high quality medicine accessible to all the patient which there is a need for in our therapy. And why we have gathered here, one the base is that when we see insomnia is just isn't just common. It is India's largest unaddressed health opportunity. This is the clinical prevalence number, and insomnia has the highest number. Close to 235 million Indians are suffering from clinical insomnia, which is bigger than migraine, diabetes, hypertension, depression, as we all know. So this is the most unaddressed disorder in India that needs to come out of shadow. And I think this program sets up the base. And we have tried to change it a little by launching India's first DORA, which is now the second largest hypnotic and one of the fastest growing hypnotic in India because of a very strong efficacy profile and a very strong safety profile, both expect and helping millions of insomnia patients in India. And not only insomnia, as Dr. Z will be talking today, we are moving beyond insomnia, exploring the role of orexin and DORAs in various neuropsychiatric conditions that Dr. Z is going to discuss today. With this, thank you for coming once again. I hope the next 1.5 hour and 2 hour remains one of the important pivotal shift in how we see insomnia as a disorder and how it can impact the life of millions of insomnia patients. With this, I'd like to call my counterpart in medical affairs, who heads the CNS and multiple sclerosis medical affairs business in India. So Dr. Dashna, over to you. Thank you.
Okay, thank you. Thanks. Good evening, everyone. A very warm welcome for today's event. Today, it's being an international speaker program. I think EISAI is doing for the first time in Kolkata city. And with a great pleasure, I would like to welcome each one of you. I'm happy to see you all on a Friday evening, that you have spared your valuable time and you have come here to listen to our keynote speaker, the renowned sleep expert, Dr. Phyllis Z. Also, today marks the Rabindranath Tagore Jayanti, a celebration of a great thinker who had believed in knowledge, unity, and learning beyond border. And thus, it makes a perfect day for us to come together and share insights across the medical community. So I once again welcome each one of you for today's event. And with this, I would like to welcome our panelists along with Dr. Z. We have our chairperson for tonight, Dr. T.K. Banerjee. He's the medical director, chief consultant neurologist of National Neurosciences Center, Kolkata. He's a former clinical staff fellow in neurology at the National Institute of Neurological Disorders and Stroke, National Institutes of Health, Bethesda, USA. He has authored more than 110 publications in leading peer-reviewed international journals. He has served as a plenary speaker and a co-chair at numerous international conferences. He's a member of the editorial board and a reviewer for several international medical journals. He's a recipient of the prestigious Mother Teresa Ratna 2021 award conferred by the All India Minorities and Weaker Section Council. His areas of interest are multiple sclerosis, stroke, epilepsy, and neuroepidemiology. So I welcome you for today's event. I would now like to welcome our moderator for today's session, Dr. Jairanjan Ram. He's a senior consultant psychiatrist, Apollo Glen Eagles Cancer Hospital, Kolkata. He has more than 35 years of clinical experience in psychiatry. He's a former local consultant in child and adolescent psychiatry at the West Berkshire Priority Care NHS Trust, Reading, United Kingdom. He's a member of the Indian Psychiatry Society, recipient of the Pondicherry University Gold Medal for securing first rank at JIPMER Pondicherry. He has published several articles in national and international journals. His areas of interest are drug abuse, de-addiction therapy, schizophrenia, treatment and management of violent behavior, bipolar disorder, child and adolescent psychiatry, and also smoking cessations. So I welcome you for today's event. With them, we have panelists who would be joining for the panel discussion. We have a senior most doctor, Professor Dr. Sagar Basu, who heads the Department of Neurology, KPC Medical College and Hospital, Kolkata. He's a former faculty member, Bangalore Institute of Neurology. He has authored multiple publications in national and international journals with over 150 citations. He has contributed several chapters to academic books in the field of neurology. He's a regular reviewer of various peer-reviewed national and international journals. He currently serves as a president of Indian Epilepsy Association, the West Bengal chapter. He's a former editor of Epilepsy News and executive member of the Association of Neuroscientists of Eastern India. He's a member of the American Academy of Neurology and the European Academy of Neurology. His areas of interest are epilepsy, cognitive neurology, and moment disorder. And his passion remains in medical education and academic teaching. Sir, I welcome you for today's event. With us, we have Dr. Gautam Saha, the former director and consultant neuropsychiatrist, Clinic Brain Neuropsychiatric Institute and Research Center, Kolkata. He's also an honorary member of the World Psychiatric Association. He's a distinguished fellow of American Psychiatry Association, president of the Indian Association of Geriatric Mental Health, immediate past president of SARC Psychiatry Federation, past president of the Indian Psychiatry Society, ex-member of World Psychiatry Association Standing Committee Scientific Section, ex-member of the Advisory Committee on Response to Emergencies, World Psychiatric Association, past honorary editor of the Indian Association of Private Psychiatry, member of the World Federation of Societies of Biological Psychiatry. He is also a National Cadet Corps Junior Division, Ministry of Defense, Government of India in the year 1978. Joining him, we have Dr. Abir Mukherjee, who is a senior psychiatrist from the Medica Super Speciality Hospital. He's also a visiting consultant at the Amri Group of Hospitals. He is actively involved in the training and clinical outreach with the Ishwar Sankalapa, an NGO supporting the homeless mentally ill patients. He holds extensive leadership roles within the Indian Psychiatry Society. He's a former treasurer of IPS East Zone, chairman of Child Psychiatry and Subspecialty Section, convener of the IAPP Child and Adolescent Psychiatry Committee, former convener of the IPS Postgraduate Education and Ethics Committee, former executive committee member, IPS West Bengal State Branch. He has authored around 40 publications and audits in the national and international journal, member of the Royal College of Psychiatrists and the Life Fellow of the Indian Psychiatric Society and West Bengal Medical Council. His areas of interest are developmental disorders in children and adults, rehabilitation psychiatry, and neuropsychiatry. We have a very young psychiatrist who would be joining the panel, who is also a sleep expert in Kolkata and a senior consultant psychiatrist, Dr. Saurav Das, who brings over 15 years of clinical expertise in psychiatry with specialized focus on sleep medicine and addiction medicine. Internationally certified in the addiction medicine by the ISAM Canada, sleep medicine by the World Sleep Federation USA. Is a founder of the Somna Sleep Clinic, a state-of-the-art facility dedicated to advanced sleep diagnostic and therapy. He has authored over 25 publications in reputed national and international medical journals. He serves as an honorary reviewer for leading journals, including Schizophrenia Research, Brain Behavior and Immunity, Psychoneuroendocrinology, Sleep and Vigilance, Annals of Thoracic Medicine, Indian Journal of Psychiatry, and others. He has contributed chapters for the global medical publishers like Springer's and Elsevier. His areas of interest remain sleep medicine, addiction, psychiatry, and neuropsychiatry. Today's session is also being webcasted to two locations. One in Tamil Nadu, in Tanjavur, where we have moderator Dr. Matesh Kumar, and I would like to welcome him for today's session. Also, the second location where this today's session is being webcasted is the Kakinada in Andhra Pradesh, and where we have two moderators, Dr. Kamaraju and Dr. Akila S. I'd like to welcome them as well for today's session. With this, I would like to welcome our chairperson and would sir, can you please introduce our keynote speaker for today's event, Dr. Filizi?
Right. Sure, it's my pleasure. Thank you very much. Sleep, as you know, I mean, you can see the crowd here and see so many people are interested in sleep. If I quote Shakespeare in Macbeth, sleep, he described that in Macbeth. Sleep is a balm of heart, mind, great nature's second course, unquote. So sleep is absolutely essential neurobiological process in a human being, and is very essential for maintaining a healthy physical and mental condition. Now, if a person is sleep deprived, they are prone to have various diseases, starting from cardiovascular disease, stroke, diabetes, hypertension. Maybe they're prone to develop Alzheimer's, and also they get all sorts of psychiatric issues. So it is absolutely essential to know the sleep and pharmacotherapies of sleep, along with the other kind of treatment. So people who suffer from insomnia, really, we had other items as sedatives over ages, but probably the benzos, the benzodiazepines, which came out in the mid 50s, I think, with chlordiazepoxide, has been really a lifesaver for these people when the sedatives have come. But with time, they have found there are certain adverse effects with the benzodiazepine group of drugs. The Z drugs have come into existence. The other group of drugs like melatonin or melatonin analogs. And now we have the new drugs, because we are understanding of the neurobiology of sleep, the physiology of sleep has been so much comprehensive that we know there is a new molecule, orexin, and by acting as a orexin receptor antagonist, this new molecule, the lemborexins, suvorexins, and other have come into existence. Now, today we are very privileged to have an authority, a world authority in sleep medicine, Professor Phyllis C.G., and welcome Dr. Z in the City of Joy, Calcutta. If I have to introduce Dr. Z, is the Benjamin and Virginia T. Bosch's professor in neurology and professor of neurobiology at the Northwestern University in Illinois, I suppose. She's the ex-president of the World Sleep Society in 2022 to 23. She's also the director of the Center for Circadian and Sleep Medicine and chief of the Division of Sleep Medicine at Northwestern University's Feinberg School of Medicine. Dr. Z is the founder of the first circadian medicine clinic in the United States. Her research has paved the way for innovative approaches to improve sleep and circadian health and sleep disorders such as insomnia and sleep apnea. She has authored more than 300 peer-reviewed original articles and wrote reviews and chapters on the topic of sleep, circadian rhythms, and sleep-wake disorders. She has also trained over 50 postdoctoral and postdoctoral students, has monitored numerous faculty members. So, Dr. Z, the podium is yours.
Very much. Can you hear me back there? Talk. Good evening, and thank you very much for coming on a Friday evening, and it's probably going to be very late. It is indeed my pleasure to be here. My first time in the city of Joy, and I already had your sweet curd, which was very, very delicious. And I am very honored to be joined by my very esteemed colleagues in neurology and psychiatry. And I'd like to thank EISAI for sponsoring me here in India. So what I thought I would do today is to give you a bit of an overview of the neurobiology of sleep and wake regulation and how the orexin system and how an orexin antagonist may play an important role in treating insomnia, and perhaps also disorders are often comorbid with insomnia, such as many of the neuropsychiatric disorders. So I would start by something that why we're all here is because we all sleep. So from the very, very beginning, there was the rotation of the earth on its axis, and therefore the development of circadian rhythms, so that your biology as an organism, whether you're plant or bacteria, you had to be synchronized to this rotation of the earth, this tremendously strong light and dark cycles. Hence, much later in evolution, we develop sleep and wake. It is the same, rest, activity, cockroach sleep as well. They have rest activity. They don't have EEG, but they still have this metabolically rest period and active period. And we have begun to know that sleep and circadian rhythms together, they regulate bioenergetics at the cellular level, at the molecular level, even mitochondrial metabolism, for example, and cellular metabolism. So when you lack sleep or you have very disturbed sleep, it increases your risk for multiple medical and psychiatric and neurological conditions. Of course, recently, a lot about inflammation. Sleep is hugely important in the area of immune regulation and inflammation. What we tend to know mostly is that of sleep and wake. So when there's light, we are active. We're supposed to be active. And during the evening, during the night time period, supposed to be sleeping. But in our modern society, we get lights all the time. Like right now, it's light at night here. We also eat at various times of the day that may be not good for our health and not in sync. So your sleep-wake timing is not in sync with your other behaviors and also with your own internal circadian rhythms. More recently, I think it's been very exciting, at least for certainly neurologists, where it's beginning to pay attention, is that sleep is a risk factor for many neurological disorders, and particularly the neurodegenerative disorders. And this is just a video of the lymphatic flow in imaging, MRI imaging, where you can see this 1 hertz per second pulsations. It is not your heartbeat.
Each of these pulsations is preceded by a slow wave during sleep, and it's thought to be flushing out the large molecules like A beta amyloid or tau that builds up in the brain in patients with Alzheimer's disease, and thus is part of the pathobiology of Alzheimer's disease. So you can see that sleep is playing more than just keeping you awake and making you happy during the day, is playing a very important role in the clearance of byproducts. So conceptually, when we think about what regulates sleep and the timing of sleep, the amount of sleep, the quality of sleep, we think of two systems. One is the sleep homeostatic system. So this is kind of conceptually a neurotransmitter or a protein that builds up during the day from the time that you wake up. So it's homeostatically regulated. It gets more and more as the day progresses, the longer you're awake. And during the night, it dissipates so that the brain now is ready to wake up and also wake up and do the activities and the metabolic activities. But at the same time, we have the circadian clock system. The center of the circadian clock is in the hypothalamus, in the area called the suprachiasmatic nucleus. And during the day, it's producing this alerting signal. So when these neurons are firing, usually during the light period, it's producing alerting signal that counteracts this tremendous buildup of the need for sleep during the day. So it is this interaction between these two systems that determines how awake you are going to be during the day and how sleepy you will be during the night. With that also comes then melatonin that is secreted by the pineal gland. And melatonin was secreted in the evening. Light blocks it, but it's secreted in the evening during the night. It actually decreases the firing rate of these neurons in the suprachiasmatic nucleus, and thus permits, it's not a hypnotic, does not make you fall asleep. It permits sleep, the homeostatic drive, to actually dissipate during the night. Now, during the day, and one of the important weight promoting agents is the orexin system. So the orexin system is high during the day and low during the night. There's a small amount of tone during the night, but it's quite low. At a time, really, they intersect. Orexins go down, melatonin begins to go up. So you can see it's a perfect synchrony and harmony of high homeostatic drive because you've been awake all day, the circadian system shutting down a bit, and also the orexin system shutting down. Of course, age, older people have more insomnia, for example. There's sex differences in insomnia and sleep disorders. Lifestyle diseases can certainly affect sleep and wake function. So how do they do that? They can either decrease the homeostatic drive for sleep. They could decrease the propensity for wakefulness, like low orexin levels, for example, or too high orexin levels can then cause this imbalance between the sleep and wake systems. And also we know with aging, there's a decrease in the amount of melatonin that is being secreted by the pineal gland because it calcifies mostly. So we think that maybe a high level of activating neurotransmitters and low levels, for example, maybe of something like melatonin or other sleep promoting molecules could explain this insomnia, both sleep onset insomnia as well as sleep maintenance insomnia. So how many of you drink coffee or take tea? No, no, come on. Yes, of course. So one of the homeostatic transmitters is adenosine, and caffeine is a adenosine receptor antagonist. So caffeine is working through the homeostatic mechanism. Melatonin is working through the chronobiotic or through the circadian mechanism. So just give you an idea how these things can be used. So we're going to focus now on the orexin system, but also on sleep and wake regulation. These orexin neurons there are only about 50,000 to 80,000 orexin-producing neurons, mainly in the lateral hypothalamus and also in the posterior hypothalamus. So a very small number of neurons. When you look at the pathways that are activated during wakefulness, or what we call activation, you can see right here. Oops. Change. Oops. when all of these things are activated, you can see these are the mononergic systems, the dopaminergic, the cholinergic nuclei in the brainstem, the reticular activating formation here. They're activated, they activate the cortex. Now, here's the little neurons of the orexin system right here. And look where they also project. The orexin system projects to all the monoaminergic systems as well as the cholinergic systems. So what it's doing is stabilizing the wake state. It's not norepinephrine, it's not dopamine, okay, but it's stabilizing the wake state because it's projecting, activating all of these systems together. Now, when you look at sleep, on the other hand, it is the opposite. There's this little nuclei here called a ventrolateral preoptic nucleus, discovered both orexin and the VLPO was discovered in 1999, okay, 1999. And here it's projecting where? The same areas that the orexin system is projecting to these monoaminergic nuclei, as well as some of the cholinergic centers. So when that nuclei is activated, the VLPO, ventrolateral preoptic nucleus, it inhibits the wake promoting system. So you've got the orexin system activating the wake promoting system. You've got this ventrolateral preoptic nucleus, which is mainly GABAergic, but it also is galaninergic, so also responds to the molecule galanine. So you can think of sleep then as an active inhibition of wake. And so you need both of these systems to be in play like a seesaw so that you can stay awake in a stable manner during the day and also sleep in a consolidated manner during the night. So the orexin protein here, you have orexin A, you have orexin B, or 1 and 2. And they sit on these two different receptors, 1 and 2. They're G activated proteins, receptors, I'm sorry. Both types of orexin play a role in sleep and wake regulation, particularly wake regulation. However, there's some differences between the two. If you look at the orexin 2 receptor, it may have a more of a role in regulating the wake to non-REM transitions as compared to the orexin 1 system, which may be more important in the wake REM transitions and also from REM sleep to REM sleep transitions. But you can see both of them are important to various degrees in this regulation. So it's thought that then over-activation, especially during the sleep period, of the orexin receptors or the orexin system itself may be responsible for some of the insomnia that we see in patients. This is theoretical. Measuring orexin in the CSF of insomnia patients has not really been consistent, not all that we know of, but this is a theoretical model. So we can think then of insomnia as a disorder of arousal or perhaps an imbalance between the sleep and wake regulatory systems. So when we think about this and we're looking, I think I can point, does this work? Oh, yeah, this works, it's perfect. So if you think about wake, then you want to activate the monoaminergic system, norepinephrine, histamine, dopamine, serotonin, and acetylcholine. And that then, when it's activated, promotes wake. The orexin system activates the system to promote wakefulness, but to stabilize wakefulness during the day. Whereas the GABA system over here in galanine from the ventrolateral preoptic nucleus actually inhibits the orexin system, right? So you can see that this is a cycle of a balance between neurotransmitters, neuropharmacology that promotes wakefulness and sleep. The orexin, as said earlier, stabilizes both wake and sleep. Patients with narcolepsy can't stay awake during the day. They fall into these sleep attacks during the day, but they also have fragmented sleep at night. So because they lack the neurotransmitter orexin. Oops, did I do that? So orexin receptors are involved, as I said earlier, or the orexin pathway in sleep and wake regulation. But because the orexin, in addition to the areas in the monoaminergic system that I just mentioned, it also projects to other areas, not projects, there's receptors in other areas of the brain, such as the prefrontal cortex, and the area near the insula. I think most interesting with the anterior cingulate gyrus, hippocampus. So you can see these are areas that are involved in some of the neuropsychiatric regulation of anxiety, for example, stress responses, and also learning and memory. So it potentially can have broader effects. And in fact, this is a slide by Tom Scammell, who shows that if you look at the orexin system as a whole, you have these inputs. You have afferent nuclei, right? Sleep and wake is one of them. It feeds sleep and wake, but you have also the circadian system. It's a beautiful diurnal rhythm, high during the day and low during the night of the orexin system, orexin levels. And also you can see that there's also other functions. It also is involved in stress response and feeding. The word orexin comes from orexin, orexigenic feeding. It was originally thought to be an appetite regulating molecule, which it is, but it was then later found that it also regulated sleep and wake. What's important is that these afferents then go into the orexin nuclei, these neurons, and then they send these pathways to the target nuclei, which I already mentioned earlier. So when you look at this area, the target nuclei are involved potentially the orexin system in stress response modulation and pain modulation and reward addiction, feeding and weight regulation, cardiometabolic function through the autonomic regulation that it has, respiration as well. I forgot to include that, cardiometabolic function, cognition, mood, and I'll show you a little bit of data in neurodegeneration. So it's a very, very important system for neuroscience overall. I'm going to show you a couple of examples that I do not want you to take home the message that the orexin system is involved in the pathobiology or physiology of neuropsychiatric disorders such as neurodegeneration or depression or things. But because the comorbid insomnia is so common among these conditions, and there's some evidence that in some of these conditions, the orexin levels are actually increased in some of these patients, that it makes sense that an orexin antagonist may be useful. So the best data that I know of right now is in neurodegenerative disorders, and particularly that of Alzheimer's disease. If you look at animal studies, mice studies, you can see that orexin overexpression is associated with higher levels of A beta amyloid accumulation, as well as accumulation of the tau protein. And that if you give a orexin antagonist, one of the DORAs, you can actually decrease the CSF levels of these of A beta amyloid. So there's something I think that's a very, very interesting concept, that there may be involved overactivity of the orexin system because you're not sleeping could actually decrease lymphatic flow, for example. So the orexin antagonist, as I said earlier, has also been studied in patients with Alzheimer's disease, mainly for their sleep and circadian effects. There's also data in humans. When you look, this is the CSF data, cerebrospinal fluid data, that there is a relationship between, in patients with Alzheimer's disease, and the degree of severity with the degree of the elevation of orexin A, I believe it was, in the CSF of these individuals. So there's some evidence that orexin system may also be elevated in these patients with Alzheimer's disease. There's also evolving data in people with Parkinson's disease. In the early stages of Parkinson's disease, as you can see over here, there is also an increase in the amount of orexin in the plasma. This was not in the CSF. However, where I think it's interesting to note that if now you go down to the patients with more severe Parkinson's disease, now there's a lower amount of orexin in the plasma. So it could be mainly something that is in response to the disease rather than part of the disease process itself. Depression is very commonly comorbid with insomnia, as well as bipolar disorder. There's some data and also in animal studies that low concentrations of the low levels of orexin is associated with also some increases or excitation of the serotonergic neurons. This is again in animal studies. So you can hypothesize potentially that when serotonin is low, orexin may actually go up, right? May actually go up as a compensatory mechanism, and therefore may contribute to the insomnia that's often comorbid in these patients, and thus again, potentially a mechanism that we can use in the kind of in this bidirectional relationship between insomnia and depression. And there is indeed some data in the literature that indicates that in patients with bipolar disease, this is in adolescents, that there's also an increase, as you can see, in the plasma levels of orexin in these individuals. It is mainly, interestingly enough, I think it's even more pronounced here in patients with bipolar disease. It's even higher in patients with bipolar disease. But I want to also, to be balanced, that the evidence is mixed. Some studies found lower levels, and there's questions about the reliability of plasma orexin assays. Maybe it's just the comorbidity, right? Maybe it's the sleep or the insomnia comorbidity rather than the disease itself. And my hypothesis is that we see these elevations potentially as compensatory mechanisms associated with the sleep disturbance that we see. Anxiety disorder also. Look at the projection of the orexin neurons to these areas. These are stress-regulating areas, anxiety and stress-regulating neurons here, or nuclei. So they project to these regions. And there's, again, some data showing that there's increased orexin plasma levels in patients with anxiety. And you can see that here as well. Again, chicken or egg, I don't know, but this seemed to make sense that they have insomnia, they have anxiety, that maybe a DORA could be potentially effective. Here's something that I think is very interesting, because based on the orexin system, if your orexin level is low, it's very hard to have addiction. That's just patients with narcolepsy hardly ever get addicted to anything because they actually don't have the effects on the nucleus accumbens. So this is potentially a very interesting medication in that one can potentially think about using in patients who have substance use or when we're withdrawing them from that. And this is just another piece of data showing that when they're trying to, in patients with alcohol dependence, they're treating for relapse prevention, that they found that during the relapse, those with the higher orexin levels were more likely to relapse than those who were not. And so again, potentially, this is just a hypothesis that maybe orexin could be a target also in patients that you're treating for substance use, especially during the withdrawal period. So let's talk about insomnia disorder. It's a clinical diagnosis for all of you. There's no sleep study that you need to do for this, but it's important to note that it's a disease in its own right. It is not secondary to or due to Parkinson's disease or depression. It is often comorbid. Insomnia predicts the risk for depression even 10, 15 years later, okay? So it's often comorbid. Now, can it exist as part of depression? Absolutely. It can also be secondary to that. It requires at least 3 nights or more of having insomnia per week and for 3 or more months chronically. And it's very important that your patients are not there because they're only allowing themselves 5 or 6 hours of time in bed, okay? That is sleep restriction, and that is not insomnia. So they are trying to sleep. They're staying in bed for 7 to 8 hours, and they still can't sleep. They have to have symptoms of difficulty initiating sleep, difficulty maintaining sleep, early morning awakening, or just dissatisfaction with their sleep, and must be accompanied by impairment of daytime function. So a patient that comes and says to me, "Doctor, I think I only sleep 6 hours, and I wake up 2 times. I sleep 7 hours, I wake 2 or 3 times, and I feel fine during the day. I have no problems. My weight is good. My cognition is good." They don't have insomnia disorder, okay? It is also a 24-hour disorder. We always call these sleep disorders, but I would say they're sleep-wake disorders. There are nighttime symptoms that we look at, but think about the daytime symptoms, the impaired concentration, impaired mood, behavior, work, and what you do during the day is what builds up that homeostatic system that I just talked about earlier. So if physical exercise, light, what you do, what you eat, your level of stress during the day, that all goes into the night. So for your patients, very, very important to think about those things. I will not be talking about cognitive behavior therapy because we really do not have time for that. Rather, I will focus on pharmacotherapy, but I want you to, it's very, very important, the slide, that when you look at any guideline in the United States and in Europe and pretty much across the world, the management of chronic insomnia, the first-line therapy is cognitive behavior therapy, which includes sleep hygiene, but it's more than sleep hygiene. And that in the US, we tend to say you can either use a pharmacotherapy with cognitive behavior therapy, or you use cognitive behavior therapy alone, but never, really, almost never, without at least cognitive behavior therapy if you're going to use pharmacotherapy, because you can use cognitive behavior therapy to taper people off of medications. So when we look at pharmacotherapy, what do we want in a drug? We want it to improve sleep latency, increase total sleep time, decrease wake time after sleep, and overall, the patient says, my sleep is good, of good quality. We also want to improve daytime function. So this is something new that many trials until very recently have not really looked at what happens during the day to these patients, only at the sleep, and very importantly, to minimize the side effects of the medications. And I think that this is the advance that we've had in the last 5+ years, is really minimizing the side effects in addition to maintaining, or in some cases, improving the efficacy of the older medications. This is a meta-analysis, systematic review and meta-analysis that was done in about studies from, that include 47,850 participants. And what it shows here on the left is a forest plot, right, of these various medications that we commonly use in the treatment of insomnia, right? All of these, you can see some of those are the Z drugs, some of those are the Z drugs, and some of those are some of the things that we use that are like antidepressants. What I think is important to note is that they all work in the short term, right? This is the 4-week period, except for the lower ones here, and there's quetiapine and Rameltian, for example, here. Now, if you look at 3 months or longer, the one that comes up is lemborexant as favoring the drug rather than placebo. This is for efficacy, right? This is for efficacy, as well as ezoplacone, which you don't have here in India. You have zoplicone, which is, I think, somewhat similar to that. Now, what about safety? So if you look at safety of some of the, like trimipramine and the Z drugs and also the Z drugs, you can see that actually it favors placebo. So there are concerns about the safety profile of these medications. And safety included falls, included AEs. So this was all things that they looked at in this meta-analysis. Whereas if you look at the DORAs, all the DORAs, we have 3 DORAs in the United States. If you look at the DORAs, and the other agents like melatonin, doxepin, and even zaleplon, which is a very short-acting Z drug, they were not significantly different in their safety profile from that of placebo in the placebo trials. So when this study, they balancing the long-term efficacy, not the short-term, long-term efficacy, tolerability, and safety, lemborexant was more favorable than ezoplacone, which was the medication that had the better long-term efficacy. So let's talk about the orexin system in insomnia. We already talked about this a little bit, just to remind you that the orexin system is believed to be activated, hyperactive in some patients with insomnia, and therefore it makes sense to dampen the arousal system, the orexin system in patients with insomnia. So I think this represents really one of the only new paradigms shift in the pharmacological treatment in the last 10 or so years. They've always been GABAergic type of medications, some more specific for some subunits of the GABA receptor, but in general, very much taking that VLPO and shutting it down, so inhibiting sleep actively. So lemborexin is a dual orexin receptor antagonist. So I will only talk about lemborexin because that's what you have available here in India that has been approved. And I wanted just to show you that it is fairly selective. All of the pathway, there's receptors in various areas of the brain. Lemborexin does not interact in vitro with these, or does not bind to GABA receptors, benzodiazepine receptors, serotonergic receptors. So it's very specific receptor binding in these various regions. And so it does then make sense, perhaps that can explain a bit of their safety profile. I will not also go very in detail in any of the trial data because you may have already seen some of this, but there's been 2 trials that are pivotal trials called Sunrise 1 and Sunrise 2 in patients with insomnia for lemborexin, and it helped improve sleep onset latency, lemborexin, and this was compared to placebo and zolpidem. Okay, it was compared to zolpidem, although it was a lower dose zolpidem, but it was compared to zolpidem as an active control. So it was significantly improved even compared to zolpidem. Most subjects on lemborexin fell asleep in less than 25 minutes, and improvements, I think important, in lemborexin was noted as early as 1 week and persisted over a 12-month period in Sunrise 2. Sleep maintenance, it helps patients stay asleep compared to placebo and zolpidem. And they gain almost, depending on the study, 50 to 60 minutes more of sleep, decrease in wake after sleep onset, which is quite substantial. And this was true for both the PSG, so the EEG, the objective recording of sleep, as well as self-reported improvements in these patients. And again, lasted for up to about 12 months. Importantly, when you look at daytime function, it improved daytime fatigue compared to placebo and And I think it's also important to note that when you look at subjective ratings of the severity of insomnia, it was favorable to lemborexin decrease the severity of insomnia. It sometimes did not get rid of all of the insomnia, but certainly improved that. This is just a little bit of the data just to show you that either the 5 or 10 milligram over here, they perform very similarly in this shorter term. This is the PSG, it's the EEG study. And the same thing if you look at sleep efficiency, right? You can see that here, sleep efficiency over here. So they're close. There's some differences at the beginning, but after about 30 days, they begin to narrow between these 2, the 5 and 10 milligrams. This is the 12-month study. This is the 6-month placebo-controlled portion right here. And then patients were then at the beginning, maybe I should just, the beginning, and then they were allowed then to cross over, and those who are on the placebo could continue then on the active drug. And you can see that the wake after sleep onset, as well as all the other sleep parameters, were maintained at the 12-month period. Safety, what about next day function? I talked about daytime fatigue. There was no next day morning residual effects on cognition. Fall risk, there was really no increase in sway compared to as measured. You can see, I'll show you the data in a little bit, as well as no significant or clinically meaningful effect on driving performance. It's something that in the US, the FDA always makes you do, the driving performance. So always do that. Here's a balance study. And in the active control, the active study, it compared to zolpidem, as you can see over here. Zolpidem in the middle of the night, lots of body balance issues, whereas you can see this with the 5 and 10 milligrams of the lemborexin. You can see this also in the bottom. This is the driving study. This is looking at lane deviation, the standard deviation of lane deviation And the bottom line is compared to zolpidem here, this was not a comparison with zolpidem, but zolpidem, flunitrazepam, and ramelteon, there was impaired driving performance in those, and lemborexant had no statistically clinically significant change. So it's safe as far as balance is concerned and motor and motor, I guess, psychomotor activity. So are there then insomnia subtypes? Is everybody going to benefit? Well, when they did the trials, they didn't take any subtypes. They took everybody who met the criteria for clinical insomnia disorder. But are there some specific subtypes based on the orexin system? It is my speculation, but based on the role of maintaining stable, prolonged periods of wakefulness during the day, that then allows, of course, the homeostat to rise and increase during the day and dissipate during the night. I could think that maybe those with hyperarousal and also those with anxiety, the patients with insomnia say to you, I can't shut my brain down, I can't shut my brain down, right? The other group would be people with circadian disorders, like shift workers. They have activation of their orexin when they're trying to sleep during the day. So perhaps dampening down could be useful. These are not FDA approved indications specifically, but I think about those when I am seeing some of my patients just based on the mechanism. What about based on the afferents and efferents, the outputs of the orexin neurons? It may be patients with anxiety, stress, comorbid. It's not treating the stress, but the insomnia is comorbid with anxiety disorders, with mood disorders, also in patients with substance abuse or history of substance abuse, where you have concerns about the Z drugs and or the benzodiazepines. Patients with neurodegenerative disorders, I say older adults where safety and special balance issues and memory issues may be of concern. And there's also some data now in chronic pain that I do not show, because in chronic pain, there may be also activation of the brain areas, maybe of the monoaminergic system, and the orexin antagonist may help. So we're going to go through two very brief exercises. This is a 65-year-old female with difficulty falling asleep and staying asleep for several years, but more severe in the past 8 months. She's a little bit overweight. Typical for the US, this is a little bit overweight. Typically takes 1 to 2 hours to fall asleep and wakes up at 3 or 4 times during the night. Just can't seem to shut her mind down at bedtime. She has a history of anxiety and depression, treated with sertraline, and has common migraine. Recently diagnosed with possible mild cognitive impairment. She just has, her memory is not very good, and maybe you have MCI. She has migraines, but it has been more frequent more recently since her insomnia. She also gets up 2 times during the night to go to the bathroom. She has mild sleep apnea, and she's been taking zolpidem 5 milligrams. And because she couldn't stay asleep with 5 milligrams, they changed it to zolpidem 6.5 milligrams, the CR or the long-acting version, the control-release version. And it helps her kind of fall asleep, but she's still waking up after 3 hours and having difficulty staying asleep. And the doctor here, she came to me with this. The doctor did not increase her to a higher dose of the zolpidem, probably because she's female, and in the U.S. it's only indicated at 5 milligrams for women, and so the lower dose. So the concerns here, well, she's concerned she may be getting Alzheimer's disease, and we have plenty of data, very strong data, that sleep fragmentation, insomnia-like symptoms can predict our risk factors for the development of cognitive impairment and Alzheimer's disease 6 or more years before the clinical diagnosis. That could be because of the lymphatic system that we talked about a little bit earlier. What about depression? She has comorbid depression, and there's very strong data, and this is just a forest plot of several studies that show that depression itself is a risk factor for, insomnia itself is a risk factor for the development of depression, again, prospectively when you look at this. So here are some of the considerations in this patient. She's got difficulty falling asleep and staying asleep. So you need something that's going to help her do that. Daytime function. She has mood, anxiety, depression, stress. Nocturia, she gets up in the middle of the night. So balance is a potential issue, and she has mild sleep apnea. So take a second or maybe 1 minute and think, what would you do? Assuming that we will all do cognitive behavioral therapy. Okay, let's assume that. What would you do? Well, what about behavioral and cognitive therapy? Absolutely. I did a DORA trial, indicated because it can help her for sleep onset and sleep maintenance insomnia, had a favorable safety profile for balance in the middle of the night, and also not likely to affect her sleep apnea. It's mild, but it's been studied in people with sleep apnea, whereas the benzodiazepines may be more of a problem. Now, another question that maybe you can think for just a second, how are you going to do that? She's on Zolpidem, right? So what are you going to do? Are you going to switch taper or cross taper with Zolpidem? Just think what you would normally do. So let's look now at some data. So there is actually a study that was done with Zolpidem to lemborexant, not crossing over. It's a switch study. There were 3 cohorts. Basically, either those were taking Zolpidem intermittently, those were taking it frequently, and at the 5 and 10 milligrams. So the bottom line is when they just stopped it. Okay, in the study, they stopped it. No tapering, they just stopped it. And you can see the data here. But 81.1% successfully transitioned from lemborexant, intermittent or frequent dosing of Zolpidem. At the end of the treatment, more lemborexant group reported that it helped them fall back to sleep compared to Zolpidem. And the safety profile, as you should always look at the prescribing information, because I'm not talking about the safety profile other than the positive, but there are side effects like sleep paralysis and maybe vivid dreaming, and also not daytime sleepiness, but morning sleepiness upon awakening. So this is another study where they did a little bit differently. This is not a EISAI sponsored study. This is an independent study. They took people 5 milligrams or adjusted so they were able to titrate to 10 milligrams of lemborexant. So the different kinds of patients on Z-drugs, patients on other like suvorexant, patients on other medications. So different kind of mixed medications. And what they did was they looked at the 1 week and they all looked at also the 2 week. The primary endpoint was how many patients were able to successfully transition to lemborexant at 2 weeks. And you can see that they not always just stopped it. They also had, for example, with some of the Z drugs, they also had a tapering schedule as they were increasing it to the 10 milligrams. 95.6% transition, very similar to the other study. And most of the patients who transitioned continued on the lemborexant. And the satisfaction and safety were evaluated at 14 weeks, and it was as you would expect for lemborexant. Next, a 52-year-old female with difficulty falling asleep for about 3 years, and more recently also difficulty staying asleep. She used to take Zolpidem 5 milligrams for about a year. Then 3 months ago was increased to 10 milligrams, but still having trouble staying asleep. Bedtime is 11:30, wakes up at 7:30, so she's in bed for 8 hours, okay? Zolpidem 10 milligrams, falls asleep in less than 1 hour, but wakes up 2 to 3 times per night, and it takes her a lot of time to fall back to sleep. Her PCP said, okay, I'm going to add trazodone 50 milligrams. And then it was increased to 100 milligrams to help maintain sleep. Now, he's waking up feeling not refreshed, feels that it's affecting his performance at work. It's probably helping him stay asleep, but he's not very happy with the side effect profile. He has also a history of alcohol abuse, but it stopped 4 years ago. He's been very dry since then, and no other really significant medications other than using melatonin intermittently. So here's a patient who's taking a BZRA and trazodone, which is not uncommon in my practice, intermittent melatonin, history of substance abuse. What would you do? What do you think are some of the considerations here? Increase the trazodone, decrease the BZRA. I mean, there's so many possibilities, right? So cognitive behavior therapy, extremely important. I started a trial of Adora, in this case, limborexin. In some other cases, I may start because I have other choices in the United States. But then the question is switch, taper off, or cross taper. What do I do with trazodone if I'm going to take this patient, taper them off, or take them off of the zolpidem? What about, should I let them use a BZRA during their taper or not? So these are all the considerations that I'm sure all of you are also thinking about, right? So think about, what would you do first? What would be, of all of these choices, what would you think you would do first? So we could do this, right? Because you stop the zolpidem, continue trazodone, add lemborexin, 5 milligrams. We could stop both zolpidem and trazodone and just add lemborexin and just titrate lemborexin to 10 milligrams. Very similar to what that study that I showed you earlier did. Or we taper zolpidem and we taper trazodone, and then we add the lemborexin. So this is when we say cross tapering, right? So we're cross tapering for a period of time. I don't know what you chose, but this is what I did. And it's not right or wrong. I just decided to do this. And sometimes it doesn't work. So I have to go backwards to one of these other methods. So we tapered off zolpidem to 5 milligrams. He was taking 10 for 2 to 3 weeks, very, very slowly. Then even further down, started lemborexin pretty much at the same time, 5 milligrams, and titrated up to 10 milligrams over probably a 2-month period, actually, while I was also tapering trazodone all at the same time. So I'm tapering both at the same time. I just halved everything. And then I was able to stop the trazodone at 2 weeks. So that's how we did. And I also allowed this patient, because he was very anxious, to have a little bit of zolpidem at his bedside if he needed it, so that he could use it intermittently if he was having difficulty falling asleep, or for that matter, mainly falling asleep at that time. So I'm going to go and end by saying that this is really an era, the beginning of the era of precision medicine for insomnia. We really did not have this armamentum of different mechanisms. It is often comorbid with medical and psychiatric conditions. So it's very important to think about what mechanism to use in patients who have comorbid conditions. I think it's also really important to think about lifestyle and behavioral components. Very, very important as part of the overall management of patients with insomnia. Ask about their environment, their bedroom, light at night, devices that they're looking at while before they go to sleep, meal timing. I recommend try to stop eating 2 to 3 hours before you go to bed. It's okay to eat late, like you're going to eat late, but you probably won't be able to go to bed until midnight tonight. And then also consider pharmacotherapy when needed. But first, look at the things that you may be able to manage behaviorally or on a cognitive basis. So our goals of treatment, of course, is to improve sleep quality in all of its domains. And what I think we're looking at the future is, if we're able to improve sleep is so important in the risk factor for the development of neurodegeneration, of metabolic and cardiovascular disorders. Could early treatment of insomnia help mitigate the development and or the expression, or at least the severity of some of these comorbid conditions? And I think that that's where we're pretty much at. I think we now need to look in the future at, data and research on the effectiveness and safety of the DORAs in insomnia that's comorbid with neurological, psychiatric, and cardiometabolic disorders. It makes sense to use them, but I think we really need that data in patient populations to really feel very comfortable, but also to know which patients will likely benefit the most from this type of a mechanism. So finally, I want to say that the future, as we say, looks good, that maybe there will be a role for the orexin antagonists in neuropsychiatric disorders, insomnia, comorbid neuropsychiatric disorders, in neurodegeneration. I did not mention delirium, but there's some really good clinical data on delirium right now that it seems like you would think that they're delirious, nothing else works, and yet the orexin antagonist seems to work. This is, of course, just from clinicians. These are not based on trial data. And finally, a lot of people are also looking at this in relation to cardiovascular and metabolic disorders. So sleep is a health imperative. It is a risk factor for most disorders that we know of. And also, if you look at sleep is still under-recognized. So if you're in the blue country, you are recognized. That means you have a lot of data on sleep health in your country, but India is in the green. You have a little bit of data. So go out there and make sleep a priority. And I thank you. It's been an honor to share this information with you.
Thank you very much, Professor G, for a wonderful, wonderful lecture. We're all enthralled. And I think what we'll is, I will say, and what we'll do is we'll go for the panel discussion, and Professor Z will also be joining in the panel discussion. The panel discussion will be moderated by Dr. Ram, and I think we have paucity of chairs. We should have more chairs here. Yeah, please. Dr. Ram will moderate the session, and if you have a question from Dr. Z lecture here, you can address the questions to her during this panel discussion. Right. In the panel discussion, our moderator will be Dr. Jayarandan Ram. And the panelists are Dr. Sagar Bose, Dr.
Abir, can you join us on the stage? Abir, Gautam, Saurabh. Right. First and foremost, I would like to thank EISAI for organizing this and bringing us to Calcutta, Dr. Z, who is an expert. And as you've all heard, that it was a very, very comprehensive presentation which answered a lot of our queries. I think we will have a round of questions for everyone and then, enable the audience to ask Dr. Z the most of the questions. So, to begin with, the senior-most person, Shagurda, what is your view on, DORAs and how do you use it? Particularly, you see a lot of complicated neurological patients because whenever we are stuck with someone, we send it to you. And what is your view on this particular molecule?
Thank you. We had a very nice presentation from Dr. Z. We have lot of things. Possibly she has described almost everything in neurology as in other spheres. Now, as a neurologist, we have to prescribe lemborexant, particularly persons with various neurological disorders, like what she has mentioned in Alzheimer's disease. Alzheimer's disease, usually in the early stages, particularly when there is some amount of hyperarousal, irritability. In those cases, this drug works wonders because we have very little options for other drugs in Alzheimer's. As similarly, in Parkinson's disease, there are lots of other sleep problems. We have RLS, we have RBDs, REM sleep behavior disorders, which possibly do not work. This drug possibly do not work in these situations. But still, some of the Parkinson's patients have insomnia per se. But there are many studies we have shown that in advanced Parkinson's disease, there is less amount of orexin in CSF. So in these cases, possibly, I don't know how will this drug will work. But in early stage of Parkinson's disease, it might be helpful. Similarly, in other disorders like epilepsy, we have seen a lot of epilepsy patients with lots of sleep disorders and others, and it's almost a bidirectional. If you have got less sleeps, you have more chance of getting seizures. But if you have more seizures, then you have a more chance of getting insomnia. So even in these patients, this drug might be helpful. We have seen in patients. And the other part in delirium, what she says, I have had experience in few patients of delirium. I have used it. Even these usual drugs we use in delirium that say haloperidols and lorazepams possibly do not work. Then you give this drug, can we seen? But very few, little experience with this. I think that's all.
Yeah, thank you. Is there any, again, regarding delirium, I know it's an uncharted territory. Do we need to go up more than 10 mg, or is there any guideline, or what does the clinical research say?
I think there are a few papers only, but there is no absolute guideline. I have not come across. May Dr. Z can.
I think those papers, they still use 5 or 10 milligrams. Yeah, 10 milligrams.
10 milligrams per day. So, I would like to ask all of you, I think let's begin with Saurabh, that what are the typical profile of patients? I think one of the typical questions which we all face, uh, who is the most suitable person? And Dr. Z presented someone with sleep problems and hyperarousal, I think would be one of the suitable candidates, because we are always struggling to find a typical profile. I know it's a very broad questions because there's no specific profile, but again, I would like to hear from all of you on what kind of situations you would go for DORA first.
Sir, I think just now ma'am has explained marvelously well, and she had mentioned that when the person is like having a component of hyperarousal, that is basically we are talking about primary insomnia cases. And in the primary insomnia cases, are the cases where orexin levels are at the highest, and obviously since it works in the orexin pathway, DORAs will be chosen most, as a first line. But again, since as psychiatrists we get patients from all backgrounds and complexities, so it becomes very difficult for us to choose that which particular patient is like a typical primary insomnia, because they are apparently rarer than the patients who are presenting with anxiety or depression and sleep problems. So that is one area. But again, what I personally do is that when I see patients who say suppose have been treated for depression or anxiety and the symptoms have gone away, but the insomnia as a residual symptom is continuing, I do think of lemborexant as a treatment for that. And also, I often use lemborexant as a maintenance treatment for insomnia. I use it very frequently because maybe in the beginning we may start with something like clonazepam or something to reduce the anxiety or other somatic symptoms, or as an add-on for depression also. But once we take it off, and if the patient complains of not able to fall asleep, I do think of adding lemborexant. And another group is that I have seen that many patients who have a long history of sleep problems spanning more than a decade, sometimes 5 years, 10 years, 15 years, have been tried on multiple sleeping pills, everything under the sun have been tried. They, I think, are like very good candidate for lemborexant, because the primary reason why they have not been responding to the other sleeping pills is that because their pathology has been different, and that particular target was not identified with the traditional sleeping pills that we had till now. In those cases, I have seen lemborexant works beautifully, but again, there's a catch. It does not does not act on the first go. Like you cannot just stop everything and give lemborexant. You have to add lemborexant and gradually taper off, just like ma'am had said. I really try to do that and remove one by one medication. Then I've seen that patients are maintaining beautifully with 5 or 10 mg of lemborexant for a long period of time. I have tried for up to 1 year. After that, I've reduced. But I think they maintain well. They do not have much side effects. It's good. It works.
Right, Abir, so
Yeah.
your first preference, and then again, suppose a patient, drug naive patient comes to you with anxiety and sleep problems. So, our go-to typical drug is an SSRI. And the person also complains of sleep problems. So usually either we use a benzodiazepine or we use mirtazapine or trazodone, depending on our preferences. But where would you place in this conundrum the DORA?
Thank you again, because I heard you in Mumbai when you came last year. So it was again a refresher course for me at least. Yes, I would agree with Saurabh with a few additions. So maybe if I'm seeing the patient for the first time, or this is the first clinical contact, I would still, my vote would be towards benzodiazepines for the first 4 weeks, simply because there are various issues with the SSRIs and SNRIs, which I think even now would be tackled by benzodiazepines. So, but I would be wary, and I would be psycho-educating the patient about the long-term use of benzodiazepines. And in any case, they would come back to me because of the dose adjustment of the SSRIs. So at the earliest, or the SNRIs, or whatever other antidepressant medications I'm using. So at the earliest opportunity, not beyond 4 to 6 weeks, I would be trying to switch over to something like a lemborexant, especially if there is that arousal problem which is still over, because we have a lot of patients. I'm this whole issue about primary and secondary insomnia is gradually losing its, sort of vogue. So basically what I would do is that if there is an arousal symptoms, there's something which used to be called a psychophysiological insomnia. So basically what it means is that the person is wary of having a good sleep. So there is a problem more so with regards to sleep induction rather than sleep maintenance and things like that. So there are plenty of choices with regards to that. We have zolpidem, we have melatonin, we have lemborexant. So it will depend on where the patient is in terms of whether it's a circadian rhythm disorder, whether it is a simply arousal mechanism sort of disorder. And I would place lemborexant in terms of if there is a typical psychophysiological insomnia, where about sleep hygiene, the other CBT therapies are not working. So that would be one group. And as Saurabh mentioned, in terms of maintenance. So we might need to use this medication or any medication for insomnia for a long period of time. Say the person has responded to SSRIs, or even initially, if I have seen the patient on SSRI or trazodone or mirtazapine and decided to stop the mirtazapine and the trazodone, but need something for a long-term continuation for the insomnia symptoms, because we all know that if insomnia persists, that is one of the most, the residual symptoms which can lead to treatment-resistant depression. So I don't want that person to get into a treatment-resistant anxiety or treatment-resistant depression. And if that would mean to continue a medication for the long term, I think this would be a very good choice.
Thank you. So Gautam, also the same question for you. With depression and anxiety, one, what would be your go-to first drug? When would you use possibly lemborexant? And what is your experience overall now that you are using the drug for a couple of years?
It's a really, if you consider or compare with the other sedative medications, it is really good. But I absolutely agree with Abid that at the initial phase, when you are using SSRI or SNRIs, there are other symptoms may be associated with like jitteriness, restlessness symptom. In those cases, benzodiazepine is the initial choice. And after that, we can definitely, after that, when we withdraw, we cannot continue benzodiazepines more than 3 to 6 weeks. During that period, tapering of the benzodiazepine and we will start these medications. And one thing is very important, especially in the elderly people, where cognitive function is impaired. In those cases, it is definitely better than any benzodiazepines as far as fall is concerned or other side effects is concerned. So elderly people, it is one of the best choices. And next is, whenever I prescribe this drug in our country, I ask before whether they can afford it or not. If they can afford, then only I prescribe. That is also very important, the cost effectiveness.
Abir has.
Yeah, addiction is also another area. I think it will gradually, because there is enough proof to suggest that orexin, there's hyperactivity of orexin and addiction. So maybe as a maintenance, not again in the initial stages in terms of detoxification and all those areas where again we have to use benzodiazepines. But again, a person who is getting into that cycle of using the drug or getting into that model of craving and all those kind of areas where the sleep is a problem, there I think.
Yeah,
Yes.
also, sir,
And one thing Dr. Shagurda told regarding the delirium, I used 2 or 3 cases, but 2 cases out of that, I used 20 milligram. And that was really good. I mean, I am not using any antipsychotic and anything else.
I think one of the, again, it would be, I would like to ask Tapo's, one of the problems in delirium is that we are using so many things. What is the primary, the primary pathology is being treated in the ICU. Then the person is on many other things. So I'm not sure how one can, with our limited clinical experience, can decide that it is the lemborexant which is working. So I have this dilemma, although I have used it, but again, Taposda, you have a huge experience. So again, in what kind of neurology patients it would be your go-to first drug, and have you ever used it in delirium or?
Uh, I use lemborexant, as Dr. Shagur Basu has said, in cases of Alzheimer's disease, a problem with this sleep-wake cycle problem. And also in few patients of Parkinson's disease, they have worked well. I mean, the Parkinson's disease patient, they're very rigid at night, very ataxic, want to go to the toilet. And the persons used to have fall very frequently. Few of my patients, I switched from benzos to lemborexant, and the family says that he's much better. I mean, he's sleeping well. There is no further event of fall. And also, the REM sleep behavioral disorder he used to have has also lessened. Yeah, so this is one thing. But for frank delirium, I have no experience in giving lemborexant, but I think that is good as well.
Yeah, I don't think the orexin for delirium or the antagonist treats the delirium because it's delirium is multimodal causes. But I think in conjunction maybe with the light, the behaviors, the orientation, light during the day, all of that, it's probably just still, again, helping with the sleep because we know, and also their circadian rhythms are off, right? They have this, the sundowning. So I think that's what maybe is happening, not so much. I don't think we're treating the delirium per se.
Such, yeah. I think the improvement marker. So what do you indicate the improvement to is something of a query. I think we will have some questions from the audience because I think there may be a lot of questions from Dibboda. Dr. Professor Dibbo Gopal Mukherjee, he's a senior psychiatrist. Yeah.
Yeah, I have a small question. You see, use of lemborexant over a period of time, what we have found is that the effect wanes off. That's a real problem. And the person who was getting or benefiting out of this drug, again, goes back to sleep disturbances. So what do we do about that?
Yeah, I don't see that frequently, but you're absolutely right. I do see that sometimes that it wanes. I would say not often, maybe 5–10%, maybe 10% of the time. Well, you don't have a choice, but I have other Doras. So I actually have tried other Doras. It's very strange. I don't know why it works, but I try a different Dora and they seem to work. So I have another Dora. I think in that case, rather than putting them back on a Z drug or a benzo, I may try a more sedating, maybe antidepressant or something like that in the meanwhile, like trazodone or something like that, so that it's easier for me to get them back. So you may want to think, I don't know, but I have this feeling that maybe if you give like a drug holiday, I don't know, maybe the receptors are filled, I don't know. But it will be interesting to see if you stop it, right? Stop it, add something for a while, and then you restart it again later. It may work. We do that in patients with narcolepsy all the
I
time.
was just wondering because even within the DORAs, there's a differential response to the orexin 1 and orexin 2 receptors. Would that might be one of the causes, isn't it? And also, I think also to refresh the CBT model as well, in
Yeah.
terms of, what there's no, it doesn't make sense with regards, because it doesn't cause dependence, it doesn't cause any tolerance. So why would there be reduced action?
No, I
So
think,
maybe
sorry to butt in, but I
I-
think
yeah.
placebo response can be a part here, like, because those patients who are, firstly, this is a very rare set of patients who are like decreasing the response after starting the medicine. And those who are having, maybe they were not responding in the first place, they were just having a placebo response in the beginning, just thinking that, okay, we are buying an expensive medicine, new medicine, it will help us sleep. But probably in those set of patients, the lemborexin was not effective in the first place. That would be my submission here.
so that might be one cause, and the other cause which I was mentioning is in terms of the arousal. That okay, now it has worked, and a sense of the subjective sense of well-being is lost, and that is why maybe to reaffirm the CBT, maybe to reaffirm the sleep hygiene measures and doing some other kinds of things might again bring back that subjective sensation of wellness, which might help.
And having them do a diary, you would be surprised that they're actually sleeping a lot better than they think. And then you show them, they go like, this is not so bad. So it's a little bit of your own cognitive therapy.
One thing, as Saurabh also mentioned, that now this in the era of the precision medicine, sometimes it is my personal experience, 2 milligram lorazepam did not work. And then I tapered up the lorazepam and started Devigo, I mean Lambroxant, and ultimately patient gets benefited. So I think some molecule may be helpful for some people.
No, absolutely. It's a very hit and miss. I think I would like to hear from you. The only side effect which some people have complained, at least for me, are nightmares initially, but that has, ended after about 7 or 10 days of. So I know that some people, it's, I think, recorded nightmares, but are there any other side effects which we need to educate the patient about, or?
Sleep paralysis. Yeah. So I tell all my patients because it's such a strange thing and it's such a fear. I mean, it's scary. So I tell them outright, I go, you may get vivid dreams. If they're good dreams, okay. But if they're not, it will go away usually. The sleep paralysis also, but the patients may feel that they cannot move usually upon awakening or very close to awakening for maybe a minute. And I tell them, don't be afraid. You're not having a stroke. This can happen. Maybe you have somebody touch you, and then you will be able, or you think hard to move your little toe, it will work. So that has happened enough times that I tell my patients about.
I think
What about the hallucinations? Would that happen as well? The hypnagogic and the
No. And there's no cataplexy either. So I didn't believe the data initially because I thought you're doing an orexin antagonist. You may get, but there was really no, but I guess it's contraindicating people with narcolepsy. So
Yeah.
please don't give it to them.
I,
But
I think this particular experience has something to do with REM rebound, because most of the patients who are given lemborexin, they are already on other sleeping aids which commonly suppress the REM sleep for a long period of time. So once they get switched to lemborexin, probably the REM is coming back, and after the initial period of REM rebound, after that substance gets back to normal level. So all the nightmares and the sleep paralysis, they are actually all REM phenomena. So
Actually, this is what happened. Yeah. So
yes,
the
that
patient
probably
was on
explains.
other. Yeah. So trust
That
Shodav
is
to
why
answer the most
cross-peppering or
complicated
they are
questions. So,
telling.
Thank you.
Not abrupt stoppage of benzodiazepine.
yeah. Bad dreams. Yeah. Disturbing dreams.
And another question from my side. I know the monotherapy is the best way to treat. If we give Lambroxan 10 milligram, if it does not work, can you add melatonin with it?
Well, practically we all do non-monotherapy, right? Because we see patients are difficult. That they're not the patient that walks in and says, I've had insomnia for 2 months, doctor, or 3 months, and I have no other comorbidities. So yes, I think I would choose the lowest dose of different mechanisms. It's like treating hypertension, treating diabetes. You know the mechanism. You don't keep going up on a beta blocker. You add a diuretic. You do this. And so I think it makes total sense. This is why I think it's so much more interesting now, because you could look at the mechanism and you could kind of look at target different mechanisms in lower doses so that you decrease side effect in general.
We have one question from the hybrid, the location, which is they are asking what are the major side effects we need to be mindful in elderly with comorbidities. Are there anything specific which we look out for, or it's kind of in general the same?
Well, except for the medications, elderly take a lot of medications. This is metabolized by the liver. So you need to be aware of that. People on Coumadin or anticoagulants, you may want to at least consider that because it can affect those levels. So interactions, right? These drug-to-drug interactions. I think falls and cognition are probably the major concerns in older adults.
Right. We will have, if there are no more questions, we'll ask Prathama. You had wanted to ask a question. Anything specific? Yeah.
What is that? We often give mirtazapine or trazodone. It's just to treat insomnia. Would that be a good practice? Because this patient need not have depression or something. And we all know that antidepressants have their own, they can cause a switch to, let's say, mania or hypomania. They have their, so how good a practice will it be to add a little bit of, let's say, mirtazapine or even trazodone in the absence of depression? This is one. And the second question I was wondering, like most of the studies, they have lemborexant has been working for 12 months or so. But like, let's say we know that sleep disturbances can, either they predict or they are a risk factor for dementia. We really don't know. Now, suppose if we treat it, then for how long? I mean, if it is a risk factor, then for how long? And these are the two questions.
I think it's always important that I always try to see the patient every 3 months, sometimes every 6 months, and I always try to take them off of their medication if possible. You can always put them back. I mean, insomnia is a continuous problem, but they do get better, and especially if your CBT is working, because that has long-lasting effects. So I try, sometimes unsuccessful. I do have patients for 5 years or longer on medications, or maybe longer, 10 years. Sometimes they never get off. But most people can successfully, maybe 6 months, maybe a year, maybe 2 years. It varies between people, but I would try always to do the behavioral therapy because I think that has the longer lasting effect. And even if it doesn't itself be sufficient, it gives them a base. It will protect them from getting these insomnia relapses. So I don't know the answer to that, but how long you can treat them, I think you treat them as long as the risk-benefit ratio favors the benefit.
I think the first part was about using mirtazapine and trazodone in
Yeah.
absence of.
Yes. It's not recommended in the guidelines to use sedating antidepressants if somebody does not have depression or anxiety. It makes total sense that they have it. So because the safety profile actually of some of these medications is not as favorable compared to some of the hypnotic medications.
Okay, thank you. So I think Abir has one more point and then we will, yeah.
Yeah, I was just wondering, it came to my mind about the COMISA, the insomnia with the obstructive sleep apnea, because obstructive sleep apnea is on the rise. And I think in terms of COMISA, it has all the ticks, this molecule. So what would be your...
Yeah. COMISA affects 40% of people with sleep apnea and vice versa. So if you have insomnia, you should also look for sleep apnea. Maybe that's why they're not getting better as well. So I think this is I think any hypnotic medication that does not affect the respiratory system or can potential for suppression would be reasonable, right? If somebody has difficulty staying asleep, maybe you add some doxepin, right? okay? If they don't have so much difficulty falling asleep, but they're difficult falling asleep, things, I think the orexin antagonists are another situation where this would be safer and likely effective. And there's been studies with this already in people with sleep apnea.
Okay, so thank you, everyone. I think it has been a thank you, Dr. Z, for again taking a masterclass on sleep. I would like to invite Darshana for the final words.
Good evening once again. And as we are wrapping our scientific fest on this ISP, Dr. Felizi, I'd like to thank my heartfelt thanks for our side and gratitude, Dr. Felizi, for your deep insight about the sleep, not only for the context of Asia and specifically for the global perspective. Thank you very much, ma'am, to come all the way and talk to us. I want to also thank TK Banerjee for chairing the session today, and Dr. Ram for moderating the session, and also a distinguished panelist, Dr. Sagar Basu, Dr. Gautam Shaha, Dr. Saurabh Das, and Dr. Abir Mukherjee. Also, there are two webcast center which is attached to this program. They are listening from outside Tanjavur and Kakinada. I'd like to thank chairperson and moderator for those two web center. Thank you very much, sir. The dinner and the cocktail are ready, so please enjoy. Thank you very much.